calling you from San Francisco, California today. Thank you for hopping on the webinar. We have an incredible agenda packed with tools to help your agency grow. Today's webinar is titled Generating a $250,000 Referral with a Readmission Program. And that seems like a big number, but we're going to walk into that number and show you how it's very realistic, and then give you tools that you can use today. You don't even have to wait till tomorrow. Tools you can use today to start marketing to hospitals, hospice, rehabs, and assisted living facilities. Again, thank you for hopping on with us today. The program will run about an hour. We will have at least 15 minutes for question and answers. This webinar right now is being recorded. We will make the broadcast available to everyone who attended within 24 hours. And we'll also make the slides and all the tools that you'll see on the webinar available as well. All of your lines are muted and you're in listen-only mode. However, throughout the webinar, you can type in any questions into the GoToWebinar panel. There should be an orange or red button in the upper right-hand corner. If you click that, the GoToWebinar panel will expand, and you can type in a question, and we will try to do our best to even answer those questions real time. However, we will address all the questions at the end of the webinar. So with those housekeeping items, let's move right into our agenda. We're going to first start out by introduction of our panelists. We're going to just set a baseline. Why are readmissions a big deal? You know, this webinar is about how can you generate a $250,000 referral program by creating a readmission program. But why are readmissions a big deal? So you may be a veteran of the home care industry, but we want to get everyone on the same page about why readmissions, why we're even talking about that today. We then want to set a baseline too for the lifetime value of a client. You know, we receive questions all the time from agencies that say, should I wrap my car? Should I hire a full-time marketer? And the good news is we have some updated data to help you make that decision, and that will paint a great backdrop in how you're marketing to hospitals, and frankly, to answer the question for you, is it worth it to execute the tactics that we'll cover on today's webinar? We will then have Steve Weiss from Hurricane Marketing give us some incredible tips to specifically target referral sources at hospitals, hospice, rehabs, assisted living, and home health agencies. Those are 5 or 6 of the highest volume referral sources today, and we'll have tips and tricks for each one of those referral sources and tools that you can begin using today. And then, of course, we'll have 10-15 minutes of Q&A. So I'd first like to introduce our first panelist. Steve Weiss is the president and CEO of Hurricane Marketing Enterprises. Steve, in addition to Hurricane Marketing Enterprises, which is a consulting firm, a sales and marketing training consulting firm for non-medical home care agencies, but prior to that, Steve also has walked the walk. He knows the joy and the challenges of owning a home care agency, and he had owned for just over 5 years an agency in New Jersey called Care Choice. He was responsible for all the operations and the marketing and sales activity, and when Steve left Care Choice to start enterprise marketing, he had grew revenues well into 6 figures and 5x over where they were at when he first joined. So Steve, thank you so much for being on the webinar today.
Derek, thank you so much, and I really appreciate it, and welcome everybody. This is me, Steve the Hurricane. So I've been looking forward to this webinar for a while. Derek put together some incredible things for you, and being able to leverage your readmission rates to grow your census, increase your profits, and increase referral sources, really, and getting places to send you referrals. It's one of those essential items that's a must-have in today's marketing and in the future if you want to get business from hospitals and other entities, as Derek mentioned. And we're going to go through some of those today and how you can position yourself as the agency of choice in your respective market, but it all starts from keeping accurate data.
Thanks, Steve. You know, Steve, as you can tell, is highly enthusiastic for today, and it's It's Steve's MO. You know, I've known Steve for 6 or 7 years now. Prior to joining ClearCare, I was working at one of the national home care brands in Philadelphia, and Steve was on my speed dial. We would text message. He was always helping our agencies grow with tips and tricks. And of course, now today's webinar, we're bringing this webinar free to all of ClearCare's customers. So today's learning, we'll have about an hour of learning, but we did want to make you aware too that you can continue, if you like, and I'm sure that you will, the style, the energy, and the passion that Steve brings. ClearCare is the primary sponsor for Steve's Hurricane Marketing Bootcamp. This is taking place August 13th and 14th. Frank, we were at this event. He holds 2 of these during the year, one of the best events that we've attended. It's specifically for private duty agencies. It's almost, if not already sold out, Steve. Close to sold out, I believe.
It's getting there, and it's still 4 months away. I mean, we did an online campaign for people to register every day. We sold a couple of tickets yesterday, and it's just, these are fantastic events. They all sell out, and these are national events that when people come and you see the testimonies in the video, and it's on our new website. It's homecaremarketing.net. And it talks all about the boot camp right there, homecaremarketing.net, all the details there. And we're going to give you a code. You see right here, CARE50 is for $50 off a registration if you can get one of those remaining tickets. So we'd love to see you there. It's fantastic. And it's really is where we're going to teach you everything that you can take from today's webinar and execute it in your field to get the referrals that you're after and grow your organizations. And it is a private duty event.
Excellent. Sounds great. I think the best quote that I saw after the conference was $30,000 of consulting for $500. That was one of the favorite quotes. I know we brought our pen and paper, and we get a lot out of it today. We also see a lot of ClearCare customers there, so it's an opportunity. We'll have a whole team there. So if you're a current customer or thinking about the software, we'll be there as well. So let's dive right into the agenda. We formed the agenda based on your feedback. So when you registered for the webinar, we asked this question: what is your biggest challenge when partnering with hospitals? And when Steve and I were forming the agenda a couple weeks ago, we said, we think we know what we want to talk about, but let's make sure that it's on point by asking that question. And some of the verbatims that we received were, can't get a meeting. And that sounds very common. We know these hospitals just many times won't let you in. Another verbatim is how to speak their language. These referral sources have certain pain points, whether it's home health or hospice, and so that resonated with us as well. So many other companies competing for their time. So I think this was referring to the discharge planner and the social worker. Even if they let you in the door, they're so busy, you have such little time to make an impact or an impression, and so we wanted to make sure we address that. And then blending in. I think this was referring to probably this, that there's so many competitors, is that everyone's saying the same thing. And how can we separate yourself, as Steve mentioned, how can you get your brand, your agency, viewed as the agency of choice, at least somewhere on their referring list. So with those verbatims, we finally tuned the agenda, and we thought that we'd set a baseline by discussing the lifetime value of a referral source. Whether you're selling Philly pretzels, home care services, or automobiles, a #1 principle in marketing is understanding how much your average customer earns in revenue for you. That way you can make informed decisions about how much to spend to actually get new business. The fantastic news is we have this data. The 2014, it's actually the 2015 benchmarking study, but it's the data from just over 800 private pay agencies from 2014, is collected by a company called Home Care Pulse. They do an annual benchmarking study, and the study was just released this week. ClearCare, we had over 100 agencies participate in that study, and we're huge advocates because this is, I print this out, it stays on my desktop, and whenever I travel to a conference, it's in my bag. The best $150 you're going to spend. Well, we wanted to bring an updated number because they actually ask agencies and track what is your lifetime value of a referral source. So one of the first questions that they ask is, what is the average lifetime value of a single private pay client? And just for terminology, average lifetime value, just, it sounds like a buzzword. It's just kind of a mouthful. Simply put, this just says, we know some clients are only with you for 1 day, but we know some clients are with you for 2 years. Some clients have a lot of care and a little bit of care. Some are hourly and some are live-in. But if you take thousands of private pay clients, and that's what this study does, to try to understand on the average, what's the average home care client worth today? That number, think about what you may think it is for your agency, but the numbers that were just recently released show that the leaders in home care are the average private pay client generates $19,000 of revenue. Now that includes caregiver earnings, right, as well. But what we're also seeing is the report is reporting the updated number is that your gross profit margins are 38%, which are still fantastic. If you're a franchise or an independent home care company today and you were in, let's say, the fast food business, your margins are maybe 2%, 3%. So agencies are seeing 90.
Derek, we lost your voice there for a second.
And what how we translate that is, the question is, what's the lifetime value of a referral source? So in the tips and tricks that we're going to share today, if you can break into one referral source, and that referral source, let's say a hospital, sends you one client every month using this number, what's the average lifetime value of one referral source? Well, we just do the simple math. We did 19,000 times 12, and that equals, right at just over a $250,000 account. And that's why these tactics today, even using these tools, it's still not easy, right? I mean, it's going to take time to develop these referral sources. You're going to need to refine your pitch, learn how to use the tools, and become comfortable. But it's worth the effort. You're always asking yourself the question. I think the other way to look at these numbers too is when you get questions about should you wrap your car, should you move out of the basement office space and move into the place that's $300 or $400 extra that has curbside visibility from traffic? Should you advertise online? Should you redo your website? Should you hire a marketer? Every time that phone rings, that's $19,000 calling if it's a client. So it's a great number just to memorize no matter what if you take that number away to help you make smart investments in your business.
And Derek, I'm going to actually jump in here, and I'm actually so glad that we saw this because the 2015 report shows a 19,000. That's up from the 2014 report, which we had said was 11,000 per client. And the 19,000 I absolutely love because it does make sense. That could be a client who's using you 12 hours a week, 3 days a week for 4 hours a visit for 2-3 years. That's 19,000 they spend with you. Or it could be a hospice client who's with you 24/7 round the clock for 4 or 5 weeks before they eventually pass away. So it's a nice benchmark there. And if you look at the value of one referral source in a hospital giving you a client once a month, that's extremely conservative. I actually know companies, my clients, people I work with, who get one hospital to refer them, and easily that hospital is sending them anywhere from 2 to 5 patients a month. So if you go on the high side of this, 5 patients a month, you're talking about 50 patients a year. I mean, that's almost $1 million right there in itself. That's more than $1 million from one referral source. So the information that we're going to talk about and how to leverage it to get into it, it just makes sense. We want to get business. The value of a client is fantastic. We need to be more statistical than we currently are, and if we can show and prove our stats, we're going to get the referrals that we're after. And like you see, one hospital, extremely conservative, one client a month is worth $250,000. And then really, I know for a fact, we're talking, 3-4 times that number for the average hospital.
Fantastic. And what we'll do when we send the slides out, we've actually written a blog post here at ClearCare It's titled A Secret 1-2 Punch When Investing in Your Home Care Agency, which walks through this number, this lifetime value of a customer and your gross profit margin, and walks you through how to make these decisions, like should you hire a marketer, should you, should you invest in the car wrap, should you invest in whatever marketing vehicle. So you'll be able to find that, or you can find that on our blog today. Okay, and then we'll set a baseline here. Just why are readmissions a big deal? Steve and I are talking about, okay, got it. I can generate a $250,000 referral from a hospital, and we keep saying this readmission talk. Why are readmissions a big deal? Well, to address that, we have to look at the Affordable Care Act. As everyone knows, it's been in the news, was passed in 2010, and it includes a number of things, right? And a few of those things are specific and address the home care industry. There is certainly the individual mandate, which we're all dealing with today, about providing health insurance to full-time equivalents. We were fortunate that some of that legislation has been stymied, at least for the moment. The other portion is the insurance marketplaces that were set up, the employer mandate as well. But what relates mostly to home care agencies is there is a specific mandate for preventing readmissions that are avoidable. And when the CMS, the Center for Medicare and Medicaid Studies, came out with their initial findings, the reason they wanted to have preventing readmissions in the Affordable Care Act is they saw that with $38 billion each year are attributed to, are spent for Medicare patients who come back to the hospital within 1 month after being discharged. And based on the CMS data, they forecasted that 17 billion of that 38 is preventable, and which is over half. And so there's an aggressive mentality at the CMS office. Say we need to get that number down. That's why you hear about accountable care organizations. There are all kinds of initiatives going on. And in 2014, actually, the penalty, we should talk about that. These hospitals, if they have a higher than the average national readmission rate, there's a formula. It's kind of complicated, but it can be looked up. Now, but they have a formula that says if you are poor performing at preventing certain conditions from staying out of the hospital once they leave, we're going to take back 3% of the reimbursement that Medicare is supposed to pay that hospital. Now, the first year that this started, the penalty was like around 1 or 2%. Now it's gone up to the maximum penalty in 2015 to 3%. Mm-hmm. It's about the penalty, and certainly at these big hospital networks, especially since they're a lot of times network hospitals, if they're missing their revenue and forecast targets by 3%, someone's upset. But it's not 10%, it's not 20%. The big hit to these hospitals is their reputation. And what we'll share here in a few minutes is that not only are they taking a financial hit if they can't keep these individuals out of the hospital, their hospital networks are the data is being published. And in one of the first couple rounds of the data, hospitals, we won't name any here, but hospitals that are nationally and regionally recognized, even teaching hospitals for geriatrics, had some of the lowest poor performing readmission rates. And so it's providing transparency for these hospitals to say, you know what, we're going to publish these rates, and it kind of attests to the Hawthorne principle, which is, let's publish the data, and folks will find a way to make those numbers improve.
And Derek, you're 100% right here too. This is a growing problem. This is a growing situation that there really is no one can really put their finger on how to do this and how to reduce it. Well, we know it's private duty is where it's at, but I saw there's a report that came out from Kaiser Health, which is one of the largest hospital systems in the country. 721 hospitals, folks. All right, 721 hospitals all across the country, all 50 states, were penalized up to 3% last year. That's a huge percentage of all the hospitals in the country that we're talking about that got these penalties for having excessive amounts of readmissions. So trust me, Your readmission data is important, and I guarantee, if you look at the list, and it's Kaiser Health put this out, you look at the list of the 721 hospitals, and we're not saying any names here, but I guarantee at least one of those hospitals, if not more, are in every single person's market on this webinar right now.
Yeah, you got it. The only exception there is Maryland, which has some exceptions on the way that they accept, they calculate and receive reimbursements, but they even have the published rates there. And Steve's absolutely right. Every state was affected, nearly every hospital was affected, and every regional metro area was affected. And for 2014, these numbers did just come out and were published by Kaiser. You could just Google Kaiser readmission rates, and a bunch of great articles pop up. But in 2015, three additional conditions to the list. So in 2014, CHF, or heart failure, heart attack, and pneumonia were part of the conditions where if someone came into the hospital for those and came back to the hospital for certain types of readmissions, they will be penalized. In 2015, emphysema and an additional lung condition and elective hip and knee surgery were also added to that list. So not only were hospitals affected, but now they're having to look out for additional conditions that they would be exposed for excessive readmissions. What does that mean? If you look into all the details of the reports, there's a lot of data, a lot of study. What it means for home care agencies is these hospitals are having issues keeping people out of the hospital when they're readmitted. And when we look at the role that private pay home care can play, being the lowest cost institutional provider of care, serving that highest cost patient population, that in non-medical home care is serving that last mile of care in the home. It's an extremely valuable way, but we need to give you the tools and the language to help approach these hospitals who are having the pain with the readmissions. So how are they doing? I'm going to go off the slides here for just a moment because this is the first tool of the webinar. We want to go to Medicare.gov. There's a compare readmission rates for your local referral sources. I'm going to take our browser right here, and I'm going to enter a zip code. So I'm going to enter a zip code here in San Francisco where the ClearCare offices are, and let's find the hospitals in our local area. Again, this is a free resource that you can use today. I'm going to pick St. Francis. I'm going to pick the Kaiser and San Francisco General and say, you know, I would like to compare their readmission rates. So now I'm going to click on this middle tab, readmissions, complications, and deaths. I'm going to click the 30-day outcome and then show graphs. Okay. When I go down, what's fantastic is you can see, let's take this one for example. We see St. Francis and Kaiser all on one graph, and we can see the number of patients that were affected, the national average, and what their average is. So in this example, you can see that San Francisco General Hospital, for this particular conditions, for clients who were, in this particular example, for this particular example is for heart failure patients. We can see that the national average is 22.7, their average is 24.7. So this is an example where their readmission rate is about 2% higher for those than the national rate for clients who are being readmitted for heart failure. You can look at all the conditions here for pneumonia, and you can compare all the hospitals. And you see this is a fantastic tool, one, just to know how are they doing. It'll give you a whole new level of a conversation to have with that referral source. And then second, you can begin comparing your rates with theirs to show them how non-medical home care can really help improve to get their number at the national average or beat that average. Okay. And before we turn it over to Steve here, I think this is probably well understood, but how do you even know what your readmission rate is? To do this, you can do it manually. You just take the number of patients or clients that you have that were referred from a hospital that had one of those conditions, one of the 5 conditions, and you tag which ones have been referred back to a hospital within the 30 days. And just, you know, a very simple example.
And Derek, I'll add to that too, hospitals or a skilled nursing facility rehab. So if somebody went from a hospital to a rehab, it's whenever they're discharged home. So you take all of those referral sources collectively. If they started with your services upon discharge from one of those places, then you go back 30 days. That's there it is, because that also counts in the readmission if it's a SNF discharge. And we'll talk more about that later, but that should be included in this group for sure.
Excellent. Thanks for that, Steve. That's where Steve's expertise really comes in handy. We know we have a lot of ClearCare customers on the line today, too. You can accomplish this by using the tag management feature for clients and running reports. It's a very simple way. We have knowledge articles in our knowledge base as well, and our support team is well-versed on how to handle this. You can shoot me an email, and I'm glad to forward you those knowledge articles, but it's very simple. You can tag these clients who are coming out. You know that they came from a hospital, and using the ClearCare platform, when you terminate a client, there's a reason, and one of those reasons is going back into the hospital. So using the tag feature, we can tag which condition they had and then pull a report that can show you those readmission rates. So very simple way to do it. If you're not using the ClearCare platform, you can obviously do this by hand today, but the better, more accurate, more consistent way that you can have that data is going to really equip you, because you can see in that Medicare data, they don't even start calculating that data unless they have several hundred patients at the hospital level, because otherwise they don't consider the data statistically significant. Now, home care agencies have a much smaller client base, so even if you have 10, 15, 20 clients over a 6 or 12-month span who've come out of a hospital, that's enough to start telling the story of how your home care prevents those readmissions and comparing that rate. So if you know the national rate for pneumonia readmissions is 17%, but only 1 out of 10 of your customers went back in the hospital, you're beating the hospital national average by 7%. There's a compelling story there that the hospitals will start to listen to. With that, I'm going to turn it over to Steve to start running through how to apply all this framework: lifetime value of a customer, readmission rates, Affordable Care Act, and Steve's going to walk through how to approach generally any referral source, but specifically hospitals, home health, rehab, and assisted living and nursing facilities.
Fantastic, and thank you so much again, Derek. I really appreciate it, and I love these 3 universal questions to ask, because the first one there, are you aware of what non-medical home care is? That's probably the biggest misconception so many times, and they may say, oh yeah, I know private duty, I understand it's fee for service and so on, but more often than not, the case managers, discharge planners, the social workers, the physicians, the nurses, the people who are in a position to make a referral to us think that we compete with the Medicare home health skilled agencies that exist out there. And that couldn't be further from the truth. We actually wrap around the Medicare benefit. We supplement and provide additional coverage and support as to what they're given from the Medicare and from the home health. And so when we come in, they think, oh yeah, another home care, another home care, another home care. But the truth is 99.9% of all of these people that we're talking to asking for referrals, they never worked in private non-medical home care before. So they really don't know it. So even though they may say, yeah, I do know it, and you may not come out and say, are you aware what non-medical home care is? You may not say it in that exact way, but make sure that they understand the difference between home health and the private duty, and make sure that they understand how limited the home health is. Home health, in all essence, covers about 6, maybe 8 hours a week of services. That's it. They get a therapist a couple of days for a few hours, and they get a nurse a couple of days for a few hours. That's pretty much all that Medicare is going to cover. Now, sometimes there's a benefit for the CNA, the nurse's aide, to go out there, but even still, it's limited. So when somebody's been in their hospital who has pneumonia, congestive heart failure is like an epidemic. They don't know how to keep these people home. It's clear cut that when the hospital has the readmission rate of 26% for the CHF patient, well, why is it 26%? It's 26% because they're sending people home on home health. So that number is also related to what the home health is providing. So clearly, there is a need for this hospital to bring in additional support. That's you. all right? How many clients do you discharge per week? This is a huge question to ask because this is how we can determine the referral potential. All right. Now I just said that congestive heart failure, 26%. So let's just go 25%. Okay. And I know that that's about the national average, but if the hospital's a 25% congestive heart failure rate, and you're talking to the social worker who deals with all the CHF patients, or you're talking to the director of case management or the director of social services who's in charge of all of her social workers and all of her people making the referrals, when you're having that conversation, if she discharges 10 patients a week with CHF, very realistic from some of these hospitals that discharge 200 and 300 patients a month. So 10 a week is very realistic. You're talking about 2 to 3 of those patients will be back within 30 days. That's 2 to 3 referrals that she should be sending to you. This comes out to helping to set expectations and how much they should send you and how often they should send to you and so on. So that's a very important number to know. And then what makes a great referral partner? And that's kind of, what are their expectations? What are they looking for? What are they, what's their protocol for referrals? How can you fit their mold? The reason why my clients are so successful, the reason why I was successful at doing this and getting referrals from all of my social workers and case managers is because I set up specific referral procedures with each of my accounts. So what worked in one place didn't work in another, and what worked with this social worker, even sometimes in the same account, I'd have 2 or 3 social workers, but they referred me in a different manner. Some wanted to shoot me a text message. Some would set the appointment up for me. Some wanted to call me. Some wanted to fax, email. Whatever it is, you set up whatever makes it easiest for them, and then follow through with it. And then obviously your turnaround time and how quickly can you get out there and so on. That's where you're going to prove that your worth and your value to them by being available, within an hour's notice to show up at their hospital. So, now Derek here, you see he's got all the information here, and I'm loving this. You can put the whole slide up, Derek. So if you look right here, before you go into a hospital, one of the most important things, and this is where so many people go wrong with this, folks. I'm a national sales trainer. I work with thousands of people every year through the boot camps and the speaking events and stuff, training people on this. And one of the most common mistakes is people don't do their research. We have to do the research. That tool that Derek just showed you before with the Medicare.gov/hospital compare, that is fantastic. Know their weaknesses before you try to get in there. And don't tell me this doesn't work. Just last week, I was speaking at my chamber event about something that had absolutely nothing to do with healthcare, but a professional from the hospital happened to be there. He came to my office yesterday. He was talking to me about what I can do to help the hospital, and I said, well, I know your hospital has problems with congestive heart failure. I can help you through my network and through what I do for a living, blah, 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 reduce your readmissions for congestive heart failure. And he was like, this is fantastic. He's getting me a meeting with the CEO. This was yesterday. I don't even own a home care company anymore. Trust me, this still works. But how did I know it? I looked at that public data beforehand. Now, when it comes to going into a hospital, who are those key contacts? And obviously, it's the people who are sending patients home, the people who are managing the care. It's the discharge planner. Now, a lot of people know about case managers and social workers, but what's the difference? Who does what? Usually, in most hospitals, the case manager is the person who's coordinating the care, communicating with the doctors, the nurses, and everybody while the patient is in the hospital, and then the social worker is usually the one handling the discharge. So it's usually a team effort. Every patient gets a case manager and a social worker, and that's usually how it goes. Now, the case managers are great because they can refer us people who are fall risks, who have dementia, Alzheimer's, and while they're in the hospital, they run the risk of injuring themselves. That's sitter service. That's a great service that we can offer for somebody while they're in the hospital to keep that person safe. And then obviously the social worker can make that referral to us upon discharge, or really, we want the referral before the person leaves, because if we can meet with them before they leave, we can actually be the person to bring them home. And that's a a good talking point to have with the social worker. Now, you see right here, ask this: what initiatives are you taking place to prevent readmissions? And this is where you come in knowing the pain points, going in ahead of time. You want to get that meeting with the director of case management. You want to get that meeting with the director of social services. But when you have that meeting, what are you presenting to her? And this is where so many agencies go wrong. And again, I'm speaking to this firsthand. I'll actually mention the name of a hospital: Robert Wood Johnson Medical Center, New Brunswick, New Jersey. I walked into that hospital many years ago and sat down with the director of case management, but I was prepared. I knew the readmission initiative. I had my readmission rates. So instead of walking in and saying, hey, we have really good caregivers, we're available 24/7, we have competitive rates, we're bonded and insured, we're the employers, the things that every other agency says, which goes back to the very second slide that Derek posted about differentiating ourselves and blending in. Everybody says those things, all right? I came in and said, well, here's our congestive heart failure program, all right? This is specifically what you're having a big trouble with, and this is our statistics on congestive heart failure patients. And she was super impressed with that. And you know what happened? A 15-minute meeting that I had scheduled with her turned out to be an hour and a half long, and she gave me a patient right there on the spot to take care of and bring home later that day. And then every time I showed up there, week after week, sometimes twice a week, I walked out with a client, or I was called there with a referral, all because I went in prepared with the statistical data that hit their biggest pain point. And that's just one hospital. All right, so we have to know all this stuff. And now you see also at the bottom too, who does this part? Who are they partnering up with home health? Those are power partners. I talk about power partners in many of the things, that not today, but that's something I talk about all the time. We can work with the home health. If I know that they're working with the VNA, if I know that they're working with Alliance, a Medicis, or whichever home health, I can work with them, and their readmission rates are what they are at a hospital level because of the home health that they're referring. So a good way to get into the hospital is to work with the home health and help reduce the home health's readmission rates, and then go into the hospital together as the collaborated or the combined solution for the CHF patient or pneumonia patient or COPD or whichever penalty diagnosis that they're feeling the most pain for. Your departments, are they part of an ACO? It all comes the same way, but know their data, come in, and then speak to the appropriate person, and really have your statistics. Statistical evidence speaks volumes, especially at the hospital level.
Steve, we have a question I think would be great to answer real time. I have a thought on it, and then you could follow up.
Sure.
The question, let's see, the question comes from Mike Hagman. Thanks for the question, Mike. He asked, what if your hospital has good readmission rates? And I know we've heard of a few agencies who, and that's why we put up here, getting your name on the list. Well, let's find out how they're doing that. A lot of these hospital networks have formed ACOs. There are now, just a few months back, there are advanced ACOs of these accountable care organizations. Kaiser also has a bunch of information. You can actually go to, just Google, where are the ACOs? And ClearCare has a blog post on this. You can actually type in your zip code and find the contact name, email address, and phone number for the leader. There are over 300 of these of the pioneer ACOs, and now there are these next-gen ACOs that are forming. That could be one possible way. They're doing something right. They probably are organized. Maybe they're using a non-medical home care company, so they kind of get it. But if not, then you can understand a lot of these hospitals have already started partnering up with ACOs, or with forming an ACO, 1, 2, including home health into that. However, a lot of those ACOs are still not using home care. Now, home care can't start an ACO, but it can participate. There are waivers in the reg that will pay for private duty home care. So it's just one suggestion on, it's a great question, Mike, because, hey, how do you arm yourself if their rates are better? I think it's just a small change of the conversation in that, hey, what are you doing? You're beating these other hospitals in the local market. What are you doing?
Yeah, I'd agree with that. And then also too, just look at all the penalty diagnoses. I mean, it's highly unlikely that a hospital is excellent at all of them. Derek named 6. So there's emphysema is a new one, hip replacements, knee replacements, joint replacements, orthopedic procedures. That's a new one that's in there. So there shouldn't be too much statistics on that, and if there is, even still, it's fine. And then also too, just take a look at everything in your market. Now, one of the things I will say too is just about every home care agency on this webinar right now has more than one hospital in their territory. And hospitals are so difficult to get into. It's going to take you 6 months to a year to get into. So be prepared for this is a battle, or this is a war. This isn't a battle or, a one-day, you're going to walk in and get referrals tomorrow. It's going to take time to get to this point. But when you go in and you're targeting, start off targeting the hospitals that have the highest rates. Start off with the ones that are the worst. Not every hospital is great, but look through all of their diagnoses. Start with their biggest pain points and then go from there. So now moving on to the skilled nursing facilities. And skilled nursing facilities, I have a special place in my heart for skilled nursing facilities. I actually feel skilled nursing facilities are the best referral source out there, because if you think about it, who are the people that are the ones that are the weakest of weak and the sickest of sick? Those are the ones that are too sick when they're finished with the hospitals to go home. If you look at national averages and readmission rates, skilled nursing facilities have higher rates of readmission than hospitals do. Why? Because they're dealing with a sicker, weaker population. So you can get great clients from skilled nursing facilities. If you understand Medicare and how Medicare works, and this is why you see the questions on there, what's your monthly Medicare census? We want to know what their Medicare census is, because people who are on Medicare usually have access to some type of funds. If they're on Medicaid, they don't. So unless you accept Medicaid, you're not really interested in the Medicaid discharge, but you are interested in the Medicare discharges. But when you find out what their Medicare census is, Medicare is only going to cover so much time in a nursing home. It's typically 20 days that they cover at 100%, and then day 21 through day 100 they cover with a copay of about $150 a day. I think it's a little bit more than that now, like $153 or something like that. But it's about $150 a day is their copay. Now, if they have a secondary insurance, they're going to get part of that, but even still, they usually have to pay something like $30, $50 as their copay. So they're going to walk out of that rehab center with a bill, okay? Now, the stroke patient who comes in and takes 3 months to get back on their feet, when their 100 days are up, this is the patient who's now faced with a choice. Either they remain in the nursing home, and because they have funds, they pay to be there, or they go home, but they have to get help. This is the exact client you're looking for. All right, this is the patient who is faced with either I stay here, and by the way, if you look up how much a nursing home costs, you're talking about $10,000, $11,000 plus a month, $100,000 a year to be in a nursing home out of pocket. So when faced with $100,000 versus $19,000, and you're in home versus a nursing home, I don't know about you, I would much rather pay the money to be remaining home and safely. So, that's what I love about skilled nursing facilities. Now, you can use your tool up here, skillednursingfacilities.org. I don't even know where you're located across the country, folks, but I guarantee if you look up your zip code, there's at least 25 places in your zip code. Within 50, look at that, within 11 miles of where Derek is in San Francisco, there's 50 facilities, all right? Now, those facilities are not created equal, folks. Out of those 50, there's probably about 4, maybe 5 that discharge the kind of volume that we're looking for. So we're not looking for every skilled nursing facility. We're looking for the ones that have the rehab patients that come through their doors and they're discharging on a monthly basis. So I'll give you an example. I like skilled nursing facilities that are discharging 50 or more patients a month. You know why? Because if they're discharging 50 patients a month, it's safe to assume that 10% of those people could benefit from extra help. 10% of 50 is 5. That's 5 referrals a month. We're not going to close all 5 of them. We can get 2, though. 2 patients a month is 24 patients a year. 24 patients a year, going back to Home Care Pulse's study with $19,000 in lifetime revenue, that's $500,000 in revenue from one well-qualified skilled nursing facility. That's why I love skilled nursing facilities so much, and it's a lot easier to get into those than it is to hospitals. Now, you're looking for the admissions and the social worker. Why you're looking for these two positions? The admissions person is the one who knows the Medicare census. It's their job to fill the building. So all of the qualifying and finding out what their discharge numbers are and what their monthly Medicare census is, and doing things with them, that's the person who's going to be able to tell you that information, and the social worker is the one who's working with the patient going home. So those are two key contexts. Now, there's other key contexts in there, but for the sake of time, these are the two that you want to focus on working with. When you come in with the admissions person, instead of coming in, hey, we can help reduce your readmissions and your hospitalizations, come in and talk about what you're willing to do with her to help her grow her census, because that's what she's really interested in. Let's collaborate on some events. Let's do an activity together. Let's go co-marketing together. Let's go to the hospitals together. All right. What can we do together? How can I help you grow your census? Well, what's in it for you, Steve? Well, simple. I want to work with you because I want to take care of your patients going home. So if you have more patients coming through your doors, you have more people to send home to me. So I have a vested interest in making sure you're successful. I'm going to spend my time helping you grow your building, all right? And then difficult discharges with social workers. Every social worker in a skilled nursing facility usually discharges anywhere from 25 to 30 patients a month apiece. So one of these skilled nursing facilities that's discharging 50 or more usually has 2 to 3 social workers working there. And when they get difficult discharges, i.e. the ones that have been there several times, the ones that have nobody to help them out at home, and if you can coordinate the care for that patient, and this goes back to Power Partners, this goes back to knowing their home health. If a social worker, and when I was doing this, and my social workers referred me, I coordinated the medical equipment. I coordinated the home health that was going to come in there. If they needed hospice, I coordinated everything. So a social worker knew if she's got to do 25 discharges this month, and she gives me these 3 that are difficult discharges and I can sign them up, I'm going to coordinate all of that. I made her job easier. She loves me forever, and she'll give me every patient she has who I've helped her identify as somebody that I can help with. And that really is what it's all about. At the last boot camp, Derek, you were there. You saw that video that I have where I filmed the social workers who talked about why they refer who they do. They both said they refer the people who make the discharge easy. They refer the people who take the referral and run with it and coordinate everything because they know they're going to do the job right and they're going to keep that person home safe and sound, because ultimately it's about a safe discharge. All right? Be the resource. Know your providers. Again, GME, which just goes right back to what I just said, home health, DME, geriatric care managers, the GCM is, so you are the resource to them. You're coordinating everything. When you bring your brochures, bring a limited number. Don't come in and give them 200 brochures. Give them 20, so that this way, after a month or so, they start to deplete. You can replace it. And then again, skilled nursing facilities, readmission rates are important to them. They don't get penalized. But you know what happens? The hospitals that send their patients to the SNFs, they do get penalized, and they know where they're sending their patients and how many of them are getting readmitted. They will stop feeding the SNFs that have too many readmissions. So they have a vested interest in knowing readmission rates. There's your in. All right, so assisted living, independent living, I'm not going to spend a lot of time on these, but these are good referral sources for the obvious reason of, they're providing care for people in the home, and the home being their assisted living or their independent living. They're keeping them there as a place for them to live. Why is the readmission rate important to them? If you know the inner workings of an assisted living, they usually charge for levels of care, right? They have levels of care. It's usually a la carte services. So if I come in, I need a shower, I need toileting assistance, I need medications, I need, a whole bunch of things. I'm getting billed, in addition to my room and board, I'm getting billed for all of that a la carte service. If I'm in the hospital, I'm still paying the rent for my room, but they're not billing me for the a la carte services because I'm not using them. So they're losing money. So they want to keep their patients in the facility. They don't want their patients moving out. That's where home care comes in. So, this is really how we work there. Now, in the assisted living, we want to target the marketing admissions person, or the person who's like the move-in specialist, the Director of Community Relations, the DCR, sometimes it's Community Relations Coordinator, CRC. That's the marketing person. and then the other person is director of nursing, and it's because there's usually a little bit of a love-hate between these two positions. Director of nursing makes sure that every person who lives there is supposed to be there and safe to be there, and then the marketing person, they're trying to fill the building and make sure they maintain 100% occupancy. Sometimes there's a conflict because the director of nursing will be discharging people to move into nursing homes who are no longer appropriate to be there, and it may be happening as fast as the marketing person is bringing new bodies in there. So this is where you come in. Your great readmission rates or your great hospitalization rates keeps patients there. You're keeping people there. You're helping the director of nursing from discharging patients out, which helps the marketing person slow the exit door while she's still filling people in. That's how you're helping them get to 100% occupancy. So residents needing supplemental care, that's exactly what I'm talking about. How often do you discharge a client that's no longer AL appropriate? On average, I'm going to say it's about 2-3 times a month. In a full 80 apartment assisted living community, 2 to 3 times a month. So that's 2 to 3 referrals a month. Not everybody's going to go with you, but you can get 1 patient a month. 1 patient a month, 12 patients a year. Derek just said $19,000 per patient. 1 patient a month from an assisted living, that's $250,000 in revenue a year from 1 referral source. We're not talking about hundreds of patients here, folks. We're talking about 1 a month from each of these accounts. Let's get cracking. Let's get out there. All right, let's move on to the next one, Derek. Home health and hospice. These are my power partners, all right? I talk about power partners all the time. Home health and hospice, all right? We're looking for, and when it comes to the social workers and finding them, that's going to be a challenge. The reason why it's a challenge to find the social workers who work with the families is because they're in the home, just like we are. So we're not going to find them easily. However, it's usually very easy for us to find that marketing representative from the hospice, from the home health. This is why I'm such a big advocate for going network marketing, going to community events and so on, because when you go to these events, who attends these events? The very marketing representatives from these companies. Make a connection with them, talk to them. What is your census? All right, census is a very important question. Many of the hospices, many of the home health agencies across the country maintain about 100 clients on their census. Now notice the words I said there, maintain, all right? Some a little bit less, some much, much more, all right? I've seen hospices that have 700, 800, 1,500 patients on their census, all right? But we'll just say the average one maintains a census of about 100, all right? Maintaining means how many people are currently getting service. Every month they're discharging 30, 40, 50, 60 patients, but they're also adding 30, 40, 50, 60 patients to maintain that number. So in a year's time, many of these agencies will provide care for like 500 or 600 people. 500 or 600 lives we're talking about here, folks, all right? 5%, just 5% is 30 out of 600, is 25 out of 500. Very, very realistic that if you get in with these marketing people and they can help introduce you to their social workers, or the marketing people are usually the ones who are admitting patients on the service, especially with hospice, they can have the conversation, you're in the situation where you need additional support, let me bring in Johnny and his company and have you speak to him. That's a referral. I got hospice referrals all the times like this, folks, and so do my clients, all right? Co-marketing. You know, this is power partners, all right? Power partners. Co-marketing. Why? Because hospice and home health are going to the same places that we are. Where do they get business? From hospitals, rehabs, skilled nursing facilities, LTECs, assisted living, independent living. They go, and they also go to physicians. These are the same places we're calling upon. We're the combined solution. What are their readmission rates? Their readmission rates should be about the hospital readmission rates. If you know your referral source facilities that you're trying to go to and you find out what their readmission rates are, and then you find who their hospice, who their home health partners are, who they're referring regularly, the rates of those facilities should be the same as those agencies because they're taking care of them in the home and they're ending up back in the rehab. So your readmission rate should be much lower. You sit down with that home health and you're like, hey, home health, your readmission rate is 17%. Mine is 10. How can we be a combined solution and get your readmission rate down to 15% or 13%? If your readmission rate is that low, would that help you get more admissions? Would that help you grow your census? And of course, the answer is yes. We're the combined solution. Let's co-market, put our heads together, and go from there. So home health, hospice, power partners. I could talk for 6 hours on this. This is the boot camp, folks. All right. So putting it together, you got to know your readmission rate. If you took nothing from today, you got to know your readmission rate. When you look up all of your local referral sources, find their readmission rates. Derek gave you all the tools here. So when you compare the two, just mathematically, because what does private home care do? We provide care, custodial care, the things that people need help with: bathing, toileting, transferring, making sure they're doing their physical therapy exercises, making sure they're taking their medications when they're supposed to. All of these things, that's what we do. So those lack of doing those things is what causes the hospitalization in the first place. Your rate should be lower. You go in as the solution to help with those things, which are the causes for readmission. They all are. Not getting to their primary care physician at PCP within a certain time period. Your rates are lower. I leverage it. I get in, and then boom, you start getting your referrals.
Awesome. Steve, we've got a ton of questions already pouring in. If we look at what we covered overview of the Affordable Care Act, the lifetime value of a customer, then drove into looking up readmission rates. And while Steve was talking, we dug into the individual tools for hospitals, home health, assisted living, rehabs, and a bunch of great tools. Let's get right into the Q&A because we've got a bunch of them here.
Now, Derek, unfortunately, I got 2 minutes because I'm double booked. I actually thought we were going to be at 3 o'clock, not 1 o'clock. So I got 2 minutes here, folks. But I'm gonna spiral through.
He's a busy guy, and I think that'll stick to our time as well. He's probably got a consulting call with someone who wants to talk about this stuff. So we'll keep you to your commitment there, Steve.
Thank you.
Someone asked Jeff Hill at the beginning, where can you get these numbers for your local hospitals? And then we covered it. We'll send out the link as well, Jeff. Sarah Shepard asked, this is great. How do you get into a hospital to get in front of a discharge planner? I think, Steve, you covered a couple of those items, but do you want to recap?
Yeah, just real quick, Sarah, I'd say get in with your power partners, find the home health, find the hospice, find the medical equipment, find the pharmacy reps, find the people who are already in the hospital and go co-market with them. Come to the boot camp. I'm going to talk all about that at the boot camp in August. All right, that's two days talking about how to get into these accounts. And what do you say to the people when you're there?
All right. We also answered Mike's question on what if your hospital has a good readmission rate. We had a question from Mark. Mark Hoskins asked, what and how does an ACO work? Are they in all markets? Mark, for time, I'm going to forward you the blog post that ClearCare wrote on the Pioneer and the Next Gen ACOs, as well as a link to find your local ACO representative. If you're anywhere in the United States, there's an ACO that's formed in your major metro market, except in extremely rural areas. So I'll send you that link, Mark. We'll take one more question here. And now we do have all the questions. So if you typed a question, we aren't able to get to it, we'll compile those, and Steve and I will personally reply and send responses back.
Absolutely. That's perfect.
Let's see, a question from Mike. I wonder, how do you find rates for things you were discussing, like the surgeries? I've used the hospital compare already. It did not see the stats. Mike, you can. The trick to expand that detail is to click the Show Graphs. You click the Show Graphs, it starts to expand more detail on the specific conditions. And while we were going through, I think the second clicking on that hospital compare, we were able to do that. But feel free to contact me directly if you need any help with that. We have a couple other questions, but we want to be respectful. We know you're very busy. Hopefully these tools have been helpful. You can begin putting these into practice. Steve and I can be contacted at any time. Our contact information, we'll send that out. And just remember, we do have the boot camp coming up in the fall. ClearCare will be there. Steve will be covering a similar topic. This is just the beginning. So thanks to all the agencies for your participation today. Thank you for the fantastic work you're doing with clients, caregivers in your communities. And Steve, thank you again so much for your expertise and guidance on the call today.
Thank you so much, Derek. I appreciate it. And thank you, everybody. Have a wonderful day.